Good afternoon, ladies and gentlemen, and welcome to today's final session of the November iteration of the Healthcare World Festival. We've had a fantastic 3 weeks. We've covered everything from the global response to coronavirus, the global recovery to coronavirus, to healthcare in Dubai, to global clinical standards, to the how to digitize your health system session on all of the different technologies that come together to create, potentially anyway, a digitally enabled health system. It's been a hell of a 3 weeks, and I want to thank everybody. I mean, in total, I think we've had over 6,000 people watching the sessions. So thank you, everybody who's participated, and thank you, everybody, for watching. And we finish, as we always try to, on a high with a really great session today on a really, really important topic. I remember a couple of the panelists here today who I last saw in person in Geneva a couple of years ago for an in-person debate. Remember those? On the potential or upcoming crisis in the global healthcare workforce. At that point, we were talking about being 30 million healthcare workers short by 2030, which in itself is a staggering number. And then, of course, along came the coronavirus pandemic. And now we have a situation where we have an exhausted, we have a demotivated global healthcare workforce. What does that mean in terms of that crisis, in terms of the numbers that we're going to be short of? And how can we possibly hope to mitigate that set of circumstances and that problem? That is the rather large topic that we'll be covering in the next hour and a half. And we have an absolutely incredible panel to do so. So to introduce them, we have Jim Campbell, who is the Director of Workforce at the WHO, who spends his entire life thinking about this problem. We have Charlotte Refson from KPMG, who was one of the co-authors of Mark Britnell's book on exactly this topic, Human, a couple of years ago. We have Jed Byrne from Health Education England, who works all around the world in education and training in healthcare. Kit Chalmers from the Tropical Healthcare Education Trust, a UK-based charity, not-for-profit, that works all around the world helping to upskill healthcare workers. We have Alistair Russell from Imperial College NHS, an organisation, very well-known NHS organisation at the forefront of this problem in the UK, as all NHS organisations are, and an offerer of education and training around the world. We have Alistair Curry to give the legal perspective as a workforce lawyer, and we have Anthony Hazar from Mott MacDonald, their head of global health security, another person who spends his life thinking about these problems, and, as you'll see in a moment, the owner of an absolutely incredible moustache. Without further ado, then, let's get into the debate. Let's get into the topic. And I think let's start with the really obvious question. And Jim, I'll come to you first, if I may. How much worse is this problem now than it was 18 months, 2 years ago when we went into the global pandemic?
Good afternoon, Steve, and good afternoon, colleagues on the panel and participants. Clearly, what we've seen since 2021-2020 is that the volume of demand in healthcare is really outstripping the capacity of our supply. The supply is being challenged by infections, deaths. Over 115,000 health and care workers around the world have lost their lives. It's affected by people having to go into isolation, people having mental health challenges, mental health illnesses, an exponential increase in mental health illness amongst health and care workers, burnout, stress, and at the same time, we are behind on routine health services, major disruptions to essential health services, managing the pandemic, and trying now to deliver the world's largest ever vaccination program that we have to get across to all adult populations. So the supply challenge is absolutely incredible. Countries are making efforts to address that, but what are we seeing is that high-income countries have got the economic demand to stimulate rapid employment, whereas low and lower middle income countries really struggling with the economic downturn to find the resources to increase the recurrent costs of labor. So in real terms, the numbers will take another 6 months or so before we have them. But in real terms, I think It's an increase of an exponential proportion.
Have you any concept of where those numbers are going to land? How much, in physical number terms, 30 million by 2030, I think, was mooted. Any rough idea about where this is going to end up?
We identified when we looked at this for the preparations in 2016, the adoption of the Global Health Strategy, the Health, Employment and Economic Commission. We saw that there would be at least economic demand would stimulate the creation of 40 million new jobs in health and care. And that is happening in high income countries. And that the biggest deficit would be in the low and lower middle income countries, an estimate of 18 million primarily. And we are not seeing progress. Population demand for healthcare, population growth, backlog of services outstripping supply there. And as you've seen from the World Bank and their autumn meetings and the IMF, real concerns that health spending will be in regression in these economies for the next 4 to 5 years, and there will be less money available to deliver healthcare.
So it really is becoming, the crisis is coming ever more quickly down the track. And Charlotte, when you worked with Mark on the book, you couldn't possibly have seen this coming, can you? If you were writing the book again now, how would you categorize the situation that we're in? You're on mute, Charlotte.
Thank you. So I agree with everything Jim says, obviously. One of the central premises of the book that I helped to research and draft was the issue of productivity. That was sort of front and central, and the need to drive productivity in the workforce. And I think that's one of the things that has been significantly impacted by the pandemic, because not only do we have huge backlogs of elective cases, but we also, the capacity to deal with them has diminished as well. We have more people in isolation. There are more rules around spacing between beds, about spacing between operations, waiting for aerosol generating procedures for things to settle. So the ability to plough through some of that work has really diminished. So I think if if we were writing it again, that productivity issue, we would have to address that more centrally.
So yeah, I mean, it's interesting. There's a couple of things that when you think about this, you think about the idea that we have a workforce that's demoralised, a workforce that's worked too hard, a workforce that, we've got to attract more people to it. What you don't think about, I mean, Jim mentioned at the very beginning of his introduction there that, we've lost millions of healthcare workers to the pandemic because they were out there dealing with sick people and caught the infection themselves. And then you also bring up the other hidden issue, which is the question of productivity and the question of actually how much more healthcare we now need to deliver. Jim, you also talked particularly about how much worse this is in developing countries. So Anthony, I'll come to you next on this one, because obviously as Mark McDonald, you deal with a lot of these developing nations. How bad is that problem in terms of the less wealthy nations? How much worse is it than it is in more developed countries?
Thanks, Steve. It's certainly a worrying time. I think Jim's already mentioned deaths and the disruption to the way people.
Anthony, you're not coming through very clearly. I think that when we were in the pre-brief, there was an issue with your microphone. It seems to be back.
Let me try and move a bit nearer. Is that any better?
Much better. Yeah. Sorry, right, you were saying.
So I was just saying that, as Jim says, it is a worrying time. A lot of people have lost their lives, and ways of working have been disrupted by the COVID-19 pandemic. Charlotte's already mentioned also that we also need to think about not just the supply side, but also the demand side. So are there better ways of working to make our health systems and ways of delivering healthcare more efficient, whether that's through task shifting, use of digital, automated systems that can enable the same number or a lower number of healthcare workers to deliver the same services that they currently deliver. So I think we need to take a look at this problem, not just from the workforce side, but also how can we look at this from a holistic health system to improve the ability to deliver universal health coverage to all people around the world, not just high income countries, but also low and middle income countries.
it's a people problem, but the solution isn't necessarily just about people. It's about management of resources. It's about digital, etc., etc. We talked about lower income countries. Alistair, obviously you work in the NHS in the UK. We are a wealthy country, but we're not immune to this problem, are we?
No, not at all, Steve. Not at all. Steve, if I could share with you some statistics of our current situation for colleagues to kind of get their head around, just to show you the challenge that we face as a trust. And just to explain, Imperial College Healthcare NHS Trust is based in Northwest London. We run 5 hospitals, all of them are teaching hospitals, and we cover all major specialties, and we also run 2 A&E centres as well. So we have 14,500 members of staff that work for us as just our trust. We treat over 1 million patients a year, but we have over 4,000 qualified nurses and midwives, and we have a further 1,200 nursing and midwife kind of support roles. Okay, so it's significant. It's over 5,000, over 5,000 nurses we have as a trust. Now, this is the challenge we've got. Our nursing vacancy. So we've got 784 vacant posts in nursing in our trust, and that's just our trust, let alone all the others. So that's a 14% total nursing workforce vacancy that we've got within our trust. So that's a problem. We've also got 293, on average, 293 nurses leaving our trust every year. So that's the turnover, and that's a turnover of 15%. Our biggest issue is with registered nurses, so what we call in the NHS Band 5. So it's kind of our qualified nurses, so entry-level qualified nurses, Band 5. And we need 388 nurses through our front door right now in order to support our service. So it's significant. Hopefully, Steve, that provides a bit of an overview from a hospital perspective, and that's one of hundreds of hospitals in the UK, the current gap in our nursing provision in particular. And I'm emphasising nursing because that's our real pinch point when it comes to workforce.
I mean, they're quite mind-boggling numbers, really, just from a relatively small subset of UK NHS hospitals in a wealthy nation. Kit, you work with healthcare providers in all sorts of interesting locations in Africa and more broadly. If that's what we're seeing in a wealthy health economy in London, what are we seeing in the places that you work in?
Yes, and I think you have to think about the baseline as well. So although we know there are shortages everywhere, there are shortages globally, but the UK has around 100 nurses per 10,000 head of population, whereas a country like Kenya, which has recently entered into an agreement with the UK to recruit nurses, has around about 12 per 10,000. So there are shortages, and then there's also an absolute lack in so many countries around the world, which, and I'm sure we'll discuss later, will be exacerbated by the need of high-income countries to support their very different service structures. So certainly we have colleagues who are part of our organisation who are also healthcare workers working abroad, and they have seen massive pressures, of course, on their services. And their healthcare workers who are in employment are suffering in the same way as UK health workers are in terms of pressures of trying to deliver non-urgent care for which there's a backlog, and also at risk of wanting to leave the profession. So we are seeing similar problems across the world, but in many other countries from a much more difficult baseline, I think.
We will grasp the thorny nettle of migration later on in the conversation. I'm sure we'll get into that in quite some detail. Alistair, from the outside looking in, as a lawyer looking at the global healthcare workforce and the healthcare workforce market, how does this look to you?
Well, I suppose as an employment lawyer, I tend to see the sharp end of the wedge, Steve, in terms of the mental state of the health workforce, which I think has been mentioned already, and the disillusionment that there is there. But that wedge and that sharp end seems to have turned into a cactus or a sea urchin, I suppose. There's been a huge rise in workforce disputes, absence management, grievances, whistleblowing issues, constructive dismissal, I know there's been a lot of press about the Great Resignation, and the data suggests that that's a global issue rather than just a UK-based issue as well, with I think it was 4.3 million resignations in August in the US alone. So of course that's not just across healthcare, that's across all sectors, but I think it is particularly pronounced in healthcare. There is this huge disillusionment amongst the workforce, and there's clearly a crisis in terms of looking at retention at least as much as recruitment in the workforce. I think that's going to be one of the big challenges that we're facing at the moment.
Increased need and decreasing supply, and then indeed an inability to hold on to the people that we have. Jed, can you put any kind of positive on this, or is it all doom and gloom?
Well, I was going to start with one other bit of doom and gloom that I don't think has been alluded with, and then maybe have a little tiny bit alluded to, maybe have a little bit of a positivity injection. So the little bit of doom and gloom is I think the governmental responses, particularly in Western economies, which we have sense checked recently, tends to be an approach for post-COVID recovery to want to sweat the system even more than has been sweated over the course of the last 21, 22 months. And I think there is a massive risk in this, in that the big unknown at the moment is how far we can push our existing healthcare workforce without them toppling over as well. And I think many of the recovery plans that I've seen potentially have a risk of making things worse rather than better, and I think that needs to be borne in mind whenever discussing this problem. From a positivity perspective, I mean, need is the mother of all invention, and I think sitting in a position where we are looking to at global partnerships, at global health security, at cultural intelligence as being the way forward for health and well-being. There are undoubtedly a plethora of opportunities that have opened up since the beginning of the pandemic to get a greater spotlight on those sorts of activity, and looking at types of leadership, upskilling, different ways of working, supply and new roles, and perhaps more recently the whole notion of frugal innovation and peer-to-peer knowledge sharing to drive down cost and increase productivity, which flows from a low income to a middle and high income country. There's been much more literature scientifically in this regard over the course of the last 3 or 4 months. So I think there are real melting pots at the moment of thought and thought leadership about how we may deliver health and well-being in a much more effective way, and whether we should be throwing all of our resource on quantity rather than looking at quality and productivity, as Charlotte suggested. So I think for me, in the position that I'm in at the moment, leading a team which is rapidly expanding, I think the opportunities are myriad, really. I think the key for us is making sure that in the enthusiasm to recover from a COVID perspective, we don't make things worse by asking more of our already overstretched global healthcare workers.
But if we're going to avoid asking more from our existing workforce, and from what Alistair says, the great resignation, more from less people, then what we clearly need to do is find more people. So let's think about that for a second. I mean, I know that there are other, there are efficiencies that we can make. There is digital healthcare that we can take into consideration. But ultimately, do we not need more people? And where are we going to find them from? Kit, I know you guys work doing a lot of education and training type projects in Africa. Is this about training more people?
I think it's about a mixture. And first I'll come back to, several people have made the points about the well-being of staff and stopping an exodus. So I think there's work to be done there in terms of supporting the existing workforce so that we actually keep the number that are there. And FET is working at the moment, particularly on whether there are ways of using global health and global health connections, because we support health partnerships who have stayed in contact through the pandemic, who have displayed the sort of solidarity that perhaps, you know, governments haven't always through the pandemic, on a small but important scale, and whether those sorts of connections are supporting healthcare workers' well-being, and potentially whether we can set up work that looks specifically at that. So I think there are well-being aspects. There's providing opportunities to existing staff in terms of training and career development that will help them to want to stay in their role. All of these things are difficult when they're under pressure, of course. And then there are many healthcare workers who are trained but are not yet employed, or who have been in employment but cannot now find roles in low and middle income countries where there is not enough money in the system to provide posts, even though they're needed. So I think there's something around the investment that's required, the support and connections that could be made between countries to help already trained healthcare workers into much needed roles, as well as brand new training, which will no doubt also be required.
Jim, I'll come to you if I may, because I remember in our very first session of the festival, you made a comment similar to that one, the one that Kit's made, that there are countries around the world, lower income countries, where there are doctors and nurses who are sitting at home because there isn't money to pay them. How much of this problem is about money? And not only from the point of view of finding the money to put much needed healthcare workers to work, but also ensuring that healthcare is a viable option for people that are looking to put years into training and into a career. How much of this problem is down to money?
Obviously, I mean, as we know from evidence around the world, health and social care is a labour-intensive sector. And that if we are setting the ambition with the Sustainable Development Goals of a universal health coverage, you know, to ensure that all essential services are available to all people with the financial protection, then there has to be a scale up of service supply. And the largest component cost, the largest investment area is into education and the recurrent cost of wages, the recurrent cost of incentives. And the financing gap to 2030 extends into the billions and billions of dollars. And like I said, the core component of that is employment. And if we look at effectively the Sustainable Development Goal, if you look at high-income countries, OECD countries, people who are already delivering on the promise of universal health coverage, 70 to 80% of their cost is on people. It is a people industry. And so we should be expecting to see a similar distribution in low and lower middle income countries as they come forward. And so this is not unexpected. So we've got to do a couple of things. Yes, the fiscal space is a real concern. We've seen the G20 has established a task force on financing for health. And that's going to be looking at trying to go with Gordon Brown, the former Prime Minister from the UK, really pushing on some of the agenda about financing for health as well. We've got to see greater domestic resources, and we've got to see greater international financial institutions to invest in social spending, education, health, social protection floors. And with that, we've got to look at performance and productivity. But at this moment in time, with a workforce that's exhausted, with a workforce and a backlog, and with the challenge that we're seeing around intention to leave, resignations, attrition, you cannot, performance and productivity, you can only ask so much of human beings without giving them the additional resources.
Sticking with the theme of money for a minute, Anthony, you guys work in the aid-funded sector in quite a lot of spaces around the world. How much is the problem of wealthier countries cutting their aid budgets because of their economic pressures post-COVID? How much is that going to affect the issue of workforce in some of those lower income countries?
It's a good question, Steve. It partly depends on which donors are funding which programs, because many programs these days look more holistically at the health system rather than funding specific positions within a health system. The issue comes back to what Kit and Jim have already shared, that there just isn't enough money to fund enough positions within these countries. What we find sometimes is that it takes so long for people to train up into positions, and then once they get there, there isn't enough funding to hire them into jobs. And that's partly why I think part of the solution, and I know we'll probably come onto this later, is to try and think differently about what those solutions might be. Not necessarily just how do we train more doctors, but do we need to reform the way medical education happens? Can we shift a number of the tasks from highly trained health professionals to lesser trained health professionals who maybe don't need 6 years of medical school, but could probably manage the job with 2 or 3 years in some kind of allied health training instead. And that could be a faster way to train up the numbers of people we need. Jim's already alluded to the fact that, at the end of the day, it's a human-driven industry, even with all the digital solutions in the world. I do think we can improve efficiency, but even with all the digital solutions in the world, we'll still need a degree of human touch. That's ultimately what people expect when they're dealing with emotions, death, illness, etc. So the way we've been working at the moment is pretty holistically. It's not trying to fix one problem, but try to bring all these different solutions together to try and fix the overarching health system.
So, Jed, coming to you then, I know that you've championed various approaches between the UK and partner countries around the world. How are you looking at these kind of solutions?
So, I think there are several ways. I think the first thing to say is that the enemy of healthcare workforce transformation is an attempt to do things too quickly. And I think there is certainly I'm experiencing at the moment within the NHS a knee-jerk response to some of the data which Alistair has shared. I mean, the national figures are we currently have 312,000 nurses in post with an anticipated vacancy rate in England alone of about 47,000, and so the figures. And we're having a much higher attrition rate at the moment. And I think there is a tendency to do things very quickly and to try and compensate for those deficiencies without recognising that we fall into two risks. One is an ethical risk, which is one you've alluded to, Steve, which is this whole notion of brain drain and acting within a selfish way as a country. And we, of course, as the oldest and largest universal health coverage system in history, have fallen into that trap periodically over the last 70 years. And it's never been to our benefit ultimately. So I think that that is a big risk. I think the other big issue for me is something which is sustainable in the medium and long term. And so the solutions that we're very much looking at the moment are mutual development of healthcare workers in terms of pure quantity supply between countries. Examples might be establishment of nursing schools within low-income countries, which are fundamentally funded by the UK, with a commitment that the large proportion of those nurses are incentivized to stay in country. And I think there are good business models around that. I think ethical recruitment within partnerships, which allows the free flow of both knowledge on a like-for-like basis and people on a like-for-like basis, are really important and very attractive, certainly to emerging economies. And we've had a significant amount of success in creating sustainable sustainable mutual benefit in India, Sri Lanka, with similar such programs. But ultimately, and I go back to what Anthony says here, this is you can't magically increase the quantity of healthcare workers overnight. You can be clever about it, and you can task shift and upskill existing workforces to work in different ways, which can have a relatively quick impact. But what you cannot do is magically wish the gap away just by employing people who simply aren't out there. And for those people who are out there that haven't got jobs, very often there is an ethical discussion and probably a government-to-government discussion about the pros and cons of moving them into a wealthier health economy and the medium and long-term impacts for that country. So it's a complicated puzzle, I think, Steve.
It's a very, very complicated puzzle indeed. Charlotte, you're an extremely clever person. I know this. So I'm going to ask you an absolutely impossible question now. Given that we don't have the money and we don't have the people, how the hell do we actually fill the required vacancies?
Well, I think it's there is no silver bullet, is there? It's a combination of everything that people have been saying. We need to increase the capacity in education, but even if you do that, if you create more graduates, more medical graduates, for example, you need to make sure that they are going to the places where they're needed. So too often, where you have this massive expansion in training capacity, I think Brazil managed to increase their medical training capacity by 200% in 20 years, incredible. And yet a lot of those people end up specialising in specialties that pay more. They end up settling in affluent urban areas rather than in the rural areas. So there are sort of, yes, training more is part of the answer, but making sure that they are training in the specialties that you need them to and going to the places they're needed to. And the importance of drawing on people in their community becomes even more important. So, Brazil is a great example of the community health worker scheme, where they've drawn people from the local communities, and they're much more likely to stay in their roles as opposed to migrating across the country. And in Canada, there's a great example of a medical school in Northern Ontario, where they recruit predominantly from the local population. They have far less migration into urban centres, and they stay in those rural areas and practice in those rural areas. So I think there are sort of those unseen sequelae. Yes, it's important to increase the number of training places, but thinking about drawing from local communities and ensuring that they're meeting the needs of the population.
Alistair Curry, to come to you. We heard Charlotte there talking about people getting involved in doing healthcare work in their communities. We heard Anthony talking about the idea that you would use less qualified people to do more. How does that work from a legal point of view, though? I mean, are you not going to get into some serious problems in terms of, how do you ensure that people are properly qualified to do these things?
Cool, that's a tough one, Steve. So yes, I suppose there've got to be risks around that, and part of it from a national and international perspective has got to be fitting the regulation to match that, and obviously fitting the training to make sure that patients end up being safe, no matter what happens. So yeah, I mean, there are going to be new legal risks that arise out of this. I've already alluded to the fact that there's a huge amount of legal action happening, workforce disputes all the time, and that really seems to be pronounced post-pandemic. I think I would just go back to what I think Jed said a little bit earlier about not changing things too fast. I think there is a really big risk that change needs to be done with care. We've got to invest in our people. We've got to train them to be ready for change. There's obviously been this huge digital acceleration. Someone was saying that digital's been accelerated by 5 years during the pandemic. Well, we've got to train our staff to be good at working with those new digital systems, so they avoid the negligence issues, so the legal claims don't flow out of that, but also so that they're just capable of delivering in the way that we need them to. And I think we need to support our staff through change, because there is going to be change, and it's got to be consultative, it's got to be engaging. We've got to have the right workforce specialists leading that change, and I think organisations need to invest much more than they have done in their HR and workforce specialists, particularly at the moment, and particularly in the UK as I see it. That change needs to be done with care. It's got to be delivered compassionately, with a view on people, and smoothly. And I think sort of hammering things through, I mean, a good example, I know it's stirred up quite a bit of debate, is the mandatory vaccinations in the UK. Was that the right thing to do, or would it be better to follow through with the engagement model and bringing staff on in a more collaborative way? I think those are the kinds of things that we've got to be thinking about. And yes, you know, too much change, too fast, too many new things are going to create legal risk. But the legal risk ultimately doesn't matter half as much as delivering safe patient care.
I think there's a really good point there, Alistair, isn't there? Which is that, you know, if we're going to include lots more healthcare workers into our workforce, if we're going to try and deal with this problem by creating volume, when we need to ensure that we maintain quality. And that the quality of the healthcare workers that we're utilising is up there. Also interested to hear what you were saying there about HR and we've talked already a little bit about retention. Alistair Russell, just again to come to you from the perspective of a real world example, you know, great one there that Alistair's just mentioned about the vaccination situation. Has that been handled in the right way? And what are you doing, or what are we doing in our healthcare system to deal with ensuring that we're retaining our staff?
Thanks, Steve. I think I won't comment on the vaccination thing. I think it's probably not my place to, but I would say that generally speaking, the engagement from our trust for the vaccine's been fantastic. Actually, the uptake's been really good. So I don't think there's only a small amount, and I'd imagine there's lots of reasons for that. So I would say generally the NHS is really behind the vaccine drive. You know, the NHS delivered the vast majority of it, as well as obviously taking the vaccine early on. So I think that's okay. I think from a retention perspective, look, it's really tough, Steve, because we are about to go into a winter now, and the hospital, you know, every day there's alerts coming up on all the computers every day. So, and we're not even really in winter. So on one side, we talk about well-being, giving staff a break, taking some time out, starting to introduce different things to promote motivation and things like that. But the reality is there's patients queuing up outside the door that need to get into hospital, and they need to be placed into beds. So it's just a really challenging time for anyone that works in hospitals, both on the front line and within the management, of how you balance that. And I suppose in the short term, Steve, I was really thinking about, from a hospital perspective, what are we doing at the moment? And we are doing our very best to try and, I suppose, and the other challenge, Steve, just come into my mind now is all this new way of working as well. You know, we don't meet face to face. You know, all our meetings are all over Teams. It's a real challenge within the hospital at the moment. Not so much communicating, but it's that kind of collegiate feel. Obviously, the teams on the wards are together face to face because they're caring for patients, but the management and the like, you know, there's that sense of distance. So we're trying to break down those barriers as much as possible to create that kind of team all in it together. And that's very much a campaign message internally at the moment. It's around really bringing us all together to face up to this Goliath of a challenge that we've now got, both winter, COVID, and also waiting lists. And everyone in the NHS wants to get on top of it. And I think that's what sits on the back of all of our minds, is the fact we've got this huge challenge on our shoulders to get through. So it's a hard question, Steve, but I think, you know, we're doing our best to try and, you know, retain as many as we can. But it's a challenging few months.
It's an interesting one, Alistair, because I mean, I've always felt that one of the great advantages that the NHS has got, because of the nature of its establishment, because of where it's come from, there's always been an enormous amount of pride amongst NHS workers that they work in a free at the point of delivery health system. I think other countries around the world would love to be able to recreate. So, yeah, it's we feel your pain. I think it's pretty bad everywhere. We're trying to go away from the kind of doom and gloom and start thinking about some real practical things that we can do.
Well,
you touched on this earlier on in the conversation. How much can we mitigate this situation with greater and more efficient use of digital healthcare?
Look, we're an acute trust. So just to explain to people listening, you've got the primary, secondary and tertiary care and acute sector within the UK. So we're very much up the complex end. We do general care, but we're very much at the complex end. So digital can play a role in it, I think, in particular around discharge and informing people when they're discharged around, how to therapy and follow-up help and things like that. Certainly with outpatients as well. So if you think about the bookends, the digital can help, at the beginning with regards to the outpatient, but it can also help on the discharge. Because for us as a hospital, what we're trying to do is create flow and movement through the hospital so we can turn over patients as effectively and safely as possible. But the reality is we run a hospital and we do a lot of complex surgery, and we have to therefore provide a lot of face-to-face care. So there's only so much digital can go. But having said that, it's around the system, isn't it? And if we can reduce the impact on the hospital, so the demand side, and I think that's where the digital stuff really comes in. If that can really focus on that side, then that reduces the demand coming into the hospital. So then we can then obviously get through and get on top of things. So I've got some other ideas, Steve, so come back later. Let's keep focused on the digital stuff, but perhaps colleagues can also comment.
Yeah, Anthony, I was going to come to you on this one, because again, you mentioned digital healthcare as a possible mitigating factor earlier on in the conversation. How can digital healthcare impact on efficiency in the workforce, perhaps in some lower income countries?
Yeah, thanks, Steve. So, I mean, the digital health is a fairly large range of service offerings. So I think that's probably the first thing to say. It covers everything from AI all the way through to just something that fills in forms for you. But irrespective, I think if I recall back to my clinical days when I used to work on the wards and what I've seen on the wards in some low middle income countries, a lot of time is still spent filling in forms.
Sorry, Anthony, can you get a bit closer to the camera again?
Sure. Yeah, hopefully that's a little bit better. Yeah, right. A lot of time is still spent filling in forms and doing quite mundane tasks. And if we could automate some of that, I'm sure it would free up a significant amount of time for health professionals to do the things that they actually care about, which is helping patients directly. And I think the lower down the chain you go from tertiary down to primary community care, there's probably more efficiencies to be made in terms of automating some of that process. If I may ask sort of throw in a question about, what's the right balance between having good quality care and having no care at all, which I guess comes back to the legal point that Alistair made. I think there is a debate to be had there. That there are certainly some people who would argue that getting some care, even if it's of lower quality, is still better than nothing at all. And I think there's still some work to be done about trying to work out exactly where that sweet spot might be.
Yeah, I mean that nods to the point that Alistair Curry made earlier on. The question I was talking around ensuring that we're fulfilling obligations in terms of having the right quality of people. I think you're absolutely right to pose the question that something is better than nothing, and it's interesting actually because it makes me recall an example around primary care in China. That I heard many years ago about the idea that the Chinese used to have probably the best primary care system in the world because they had a barefoot doctor in every village who mostly was giving out kind of galangal roots and God knows what, sort of traditional Chinese remedies. But at the end of the day, at least they had something. Whereas the westernization of Chinese primary care has pretty much meant that there's a bit of a gap there now. So I think it's a really good point that you raised. So I see some hands going up. So Kit, I'll come to you next and then to Jim.
So just following on from that point about lower quality care versus no care, so just a brief point to throw in. Yes, there has to be a balance to be struck at what you're aiming for, but the first tenet of medical ethics as international development is first do no harm, and there is no doubt that you need a bare minimum level of quality to avoid doing harm. Sometimes something is worse than nothing, in fact, and we need to be careful that if we're lowering standards of quality, we're not reaching that point.
No, very, very good point. Well made. Jim, to come to you.
Yeah, Steve, I think this is an important discussion, and we need to be extremely clear with the language that we use, because quality of care is provided by teams of healthcare, social care professionals, supported by the management infrastructure. We shouldn't associate quality uniquely with an occupational title. This is about the scope of practice. We know that the evidence is absolutely clear. Cochrane reviews, Campbell reviews, etc. Certain occupations who are educated, regulated, and enabled to work to their full scope of practice can provide huge amounts of primary healthcare, nurse-led services, advanced practice, etc., etc. The roles of community health workers, again, educated, regulated, licensed, or at least accredited in terms of their education, providing a scope of practice with 1 year's education or 6 months education, really looking at vocational training, can do a lot of the prevention, surveillance, community engagement, public health activities. So let's not, it's a scope of practice. It's not people who are less trained than somebody else. It's not someone who is cheaper than someone else. It is actually the essential services that need to be delivered, the competencies required, and an education and quality of care system that enables that to be replicated continuously with appropriate clinical controls, appropriate human resource, financial controls. And that's, if you go back to some of the WHO publications in the last 4 or 5 years on health workforce, we don't talk about task shifting from a physician to other occupations or from a nurse to a community health worker. We talk about the role of a multidisciplinary team, their scope of practice, their education, and their responsibilities. So just to be a little bit careful on the language, because we're veering into something which is trying to associate quality with an occupation.
I think it's a really important point that you raised, Jim. I mean, the phrase that I've heard used before, and I think this is kind of what Anthony was nodding towards earlier, was working up to the limit of your license. So it comes back to that point around what we don't want to do is underutilize our health workforce. So you don't want highly qualified nurses, doctors, doing things that somebody with a lower level license or a lower level of regulation is able to do. So I think it's a really, really important point. Charlotte, you've got your hand up.
Thank you. I don't mean to veer off again, but I was going to come back to the digital stuff, because I think
I was going back there in a second.
I was just going to talk about the value of digital, and particularly remote consultation and remote monitoring, especially in primary care. And there is value, I think, in that kind of, there is some time saved per encounter, but that's not really where you find the value in it. I think a lot of it, the value comes in being able to extend services into rural and remote areas, to reduce travel times, to use these kind of remote services to virtually triage people and divert demand and navigate people to the right places. And also having remote monitoring allows you to do things in the community that people might otherwise have to be in hospital for. And I mean, the sort of the COVID wards, community wards, are a really good example of that. So it's just trying to think of that, those virtual consultations, everyone just thinks about, having a GP consultation via Zoom, but it's not just that. The value comes from being able to change the way we work and change the flow of work.
I think there's 2 points really that come out of that. One is the fact that you mentioned the idea of being able to use remote consultation, be able to use digital technology to deliver in more rural areas. And I mean, we're going to talk a little bit later on in the conversation about, and Jim has already nodded towards the question of universal health coverage and that as a sustainable development goal. And at the end of the day, the use of digital healthcare to reach communities who otherwise would not have immediate access to health workers or are many, many miles away from healthcare workers is a really, really important point. The second point, I think, that is something that certainly I'm very passionate about, is the idea of actually how do you make demand more efficient at the different levels of a health system. So, for example, you start off with the idea, and I know this isn't exclusively why primary care was invented, but one of the great consequences of having good primary care is that it provides triage to a hospital. So I come back to that example about a lack of primary care in China and the joke around what do you do if you've got a cold in China? You go and queue up outside the nearest acute hospital. Obviously, that's not a sustainable way of delivering care. So you go to a GP and the GP then routes you onto the next stage of the health system. Okay, so that's great. Having primary care stops you from overloading the acute care sector. But what happens when the primary care sector gets overloaded? Well, actually, that's the point where digital health can make a huge difference, because at the end of the day, if you can use digital technology, remote triage tools to actually say to somebody, no, you've got a bone in your foot, you can just stay at home and have an aspirin rather than overloading the GP, that also creates efficiency within the health system. Anyway, I'm supposed to be asking the questions, not answering them. So I'll stop trying to do that and go to Jed, who I know has a couple of points he wants to make on the digital point.
Yeah, thanks, Steve. Much appreciated. So I've been listening to this, and I've just been taking a few soundings and thinking about some stuff. And I just wanted to mention 3 programs which we're either doing or interested in at the moment that moves us away from the frontline telemedicine discussion. So, the first of these comes back to Alistair's point. So I as an elderly physician recognise that effective healthcare is codependent on informal relationship, and actually that is extremely difficult to achieve within a healthcare setting. However, if the pandemic has taught us anything, it's taught us that our peer-to-peer knowledge sharing, cross-border relationships are absolutely essential for future global health security. And I think and in fact, this has stimulated us into action in numerous different ways. So we've established 3 MDTs now, one between Cambridge and Kampala, which is in, I can't even remember what it's in now, in intensive care, one between the RChem and a regional hospital in Kampala, and the third is a breast MDT between Manchester Foundation Trust and Mombasa. Now, these are very experimental at the moment, but the whole underpinning principle of that was to use digital technologies to develop peer-to-peer relationships and long-standing action learning sets. And I think there is something about global relationships which can be managed to a degree by health technology, which I think may prove to be extremely beneficial in terms of flattening the playing field for the identification of future leadership, mentorship, joint development, etc. So that's number one. The second is this whole rise in blended learning as a way of developing healthcare workers. There are numerous examples. There are 3 or 4 in the UK which HWF have sponsored, where the curriculum is fundamentally delivered digitally, but the hands-on stuff is jointly delivered on site where that individual is using is learning digitally. And I think that sort of blended cross-border learning approach is not only good for undergraduate activity, but also good for professional development and task shifting. And I think we need to look at that. And then the third element, which we're very interested in terms of IT at the moment, is using NGOs as champions for the use of low-cost, high-volume IT telemedicine in low and middle income countries. And this can either be, getting people involved in sort of electronic patient record type activity, or frankly, it can just be health navigation. But I think there is something about using our existing networks, particularly in low, middle, and emerging economies, of NGOs to get individuals who are gravitating or migratory to be champions for those potential digital solutions.
I think another very interesting point you raised, actually, at the very beginning of that conversation, is the fact that we need to think about digital technology not just in terms of the delivery of remote consultations. And actually, we're talking about workforce here. So, Alistair, I'll come to you if I may. Digital technology can also be used, can it not, to manage the workforce? You talked about the need for HR, the need for looking after the staff. So how can we use digital healthcare to do that?
Yeah, I'm assuming I'm the Alistair you're talking to about
you
this
are,
one,
sorry,
Steve.
I need to make sure I'm identifying my Alistairs.
That's fine. Yes, I would say with some care, actually, and particularly the reason I'm saying that is because of the whole digital inequality issue. And I think there are some real risks around this. And yes, obviously, you know, digital and the digital acceleration has been extraordinary in the last couple of years. And there are some really clear workforce benefits, you know, higher degree of self-determination, shifting from replacing jobs to making jobs better and removing repetitive tasks, augmenting roles, collaboration. I loved the idea that Jeb mentioned of Cambridge and Kampala working together and sort of international collaboration there. And actually, we're seeing an awful lot of that. So I'm getting a lot of queries from UK-based NHS organisations asking me, particularly in mental health, about how they can engage with workers living abroad, whether in the EU, which is a bit easier, or outside the EU, further afield. And the main problem tends to be data sharing and the risks of data security around that. So cross-border technological management of staff is definitely an area that is going to be difficult and potentially fraught with quite a lot of legal risks. But sorry, coming back, diverged quite a long way from what I was going to talk about there. But coming back to digital equality, I think that we do need to just look out for this and the risks that are created there, whether it's risks of emphasizing or perpetuating existing inequalities along, you know, inclusivity lines, along racial, class, whatever protected characteristic. It might be social, socioeconomic, of course, by geography, national or regional, based on internet speeds, or by sector even. So I was in a workforce forum a couple of months ago with Martin Green, the CEO of Social Care England, and he was raising the point that, of course, well, he referred to social care as a data desert, and you know, the huge disparity in digital ability or digital resources between social care and healthcare organisations, and of course between regions, as I say, and then between different protected characteristics. There is a really big risk there. So I think when we're managing staff, when we're thinking about managing staff globally, and the benefits that digital can bring, we also just need to be really careful to think about how we make sure that that's done in an inclusive way, and that all staff are brought on board, and that, you know, digital AI, for example, doesn't just go out there and replace the roles that are traditionally delivered by women or those of lowest, you know, different social economic groups, and that it doesn't target existing inequalities, and that it really does become an inclusive digital revolution rather than something that builds those problems.
Yeah, you wanted to come in on this one.
I wanted to touch on the broader uses of digital technology, but I would just echo Alistair's comments about equality and the risks of rolling things out quickly and exacerbating issues and creating a real digital divide, so, which we see, you know, globally very much, as well as within different parts of the UK. And so just beyond the workforce, it's managing the workforce and managing consultations. Just, you know, we've all seen, as you've mentioned, a huge boom in digital connections and digital literacy really over the last period, and we see that becoming incredibly useful in terms of cross-global connections. And just, you know, one of many sort of global partnership examples relates to the very difficult situation in Myanmar, where the healthcare system has virtually collapsed as a result of first the coup and then COVID. And the UK health community with connections to Myanmar, including diaspora healthcare workers, have really come together to support their colleagues in Myanmar with online platforms, with online training, with the support of, for example, Royal Colleges, and are now sort of managing to train over 3,000 nurses in Myanmar to support their care to patients and try and preserve quality in a difficult situation. So obviously lots of uses for digital technology.
While we're with you, Kit, I did have a question I wanted to pose to you, which was that, you know, it's all very well talking about the ways in which digital healthcare can provide a positive effect on the healthcare workforce issue. But, you know, Alistair talked there about digital inequality. I think he was talking about that within a community, within the global community. Is there not digital inequality? And in some of those lower income countries in which you work, is digital healthcare even possible, given the financial and infrastructure challenges that those countries face?
So certainly there's digital inequality. In some ways, it may be less than other inequalities. So in a country that has poor infrastructure in terms of roads and transport, for example, it may be that you can reach people more easily through digital connections. And we know that in some ways, technology has leapfrogged in many low and middle income countries from no communication devices to mobile phones, which are owned by very many, you know, huge proportions of people in low and middle income countries. But yes, we need to be careful that simply having a mobile phone doesn't mean you can access the internet, doesn't necessarily mean that you can read complex information, but there may be ways of reaching people in other ways remotely. So I think, yes, global inequality, that doesn't rule out using digital technology, but we just need to do it with care and planning and being aware of where those gaps are and taking that into account in planning those services.
There's also a risk, isn't there, of leaving people behind, particularly when you're talking about rural communities and older populations. Even in the UK, the older population gets left behind somewhat by digital healthcare. I want to leave the topic of digital behind. We've got about half an hour left, so I think it's time to grasp the thorny nettle and start thinking about that question of migration, because at the end of the day, we're talking about a global workforce crisis. We're talking about inequality between more wealthy nations and less wealthy nations. So are we at risk of creating greater health inequality when richer nations that can afford to offer higher wages to healthcare workers to leave their local economies are being drained away from where they're most needed? And I know, Jim, that you've got some strong feelings and some strong thoughts on this. So I'll start with you, if I may.
This is an emotive subject, obviously, because it encompasses many different perspectives. I think what we've got is a strong evidence base that we can refer to and look at this and then start to break it down. Migration has existed for centuries and will continue. Health and social care depends as an economic sector, has a high dependence on tertiary educated, licensed, regulated professionals who, as a result, are in high demand in any national setting or international setting. And we've heard from Jed and from Alistair just on the vacancies for a tertiary educated registered nurse in the UK NHS. Their migration so it continues to grow as demand for healthcare grows and as capacity in economic jurisdictions is increasing to be able to recruit more and additional and right-size your workforce against population need. So we can't prevent migration. The WHO Global Code of Practice on the international recruitment of health personnel does not set out to prevent migration. What it just suggests is that there should be an appropriate set of principles that are applied to this phenomena. That where possible, there should be mutual benefit for source and destination countries and for the health worker themselves. The rights of the workers should be considered. That the principles of do no harm should be there. You should understand the impact of recruiting from a source country in terms of how that may disrupt population access to healthcare. And you should do a bit of due diligence and be responsible in your roles. So the evidence points to that as having a better added value. Again, we keep talking about human behavior and the human needs of healthcare. It's also human nature to try to become a master your topic, to try and improve your career development opportunities, to try and give to your family, your community, a greater opportunity for education and life experiences. That's quite normal. So migration is going to happen anyway. Let's do it in a responsible way based on some of the evidence, rather than leaving it to the free market.
So from that point of view, and Charlotte, I'll come to you on this one. From that point of view, is migration necessarily a bad thing? Because at the end of the day, you might be losing healthcare workers to a richer health system, but when eventually they do come back, they come back with greater skills and knowledge.
I don't think there's anything wrong with being able to travel to different countries and learn new skills and share that kind of professional knowledge. I think and I agree with Jim. It's human nature to want to do the best in your role and to want to travel the world and do that. But that term, that mutual benefit, that's where that's what's got to be concentrated on. And I think that the issue is whether people do go back, because the implicit in your question was that they do, and sometimes they might not. Sometimes it's not just about pay either. It's not just because you might earn more in the States or the UK or wherever it is you're migrating to. It's sometimes because the conditions where you're working are just so difficult. You hear reports about, not even reports, you're having to operate at night and then the power generator goes down and you're doing a cesarean by the light of your anaesthetist's mobile phone. It's just that's stressful. So sometimes it's not just pay, it's conditions as well. So there's not just a pull, there is sometimes a bit of a push as well.
So Jed, to come to you, how do we make sure that we don't end up not leaving enough people behind, so to speak?
Okay, so it's difficult to know how to précis this, but so my first comment on what Jim and Charlotte have said, just by an example, we have noticed a paradigm shift in medicine migration in the UK over the course of the last decade, and particularly medical recruitment from Southwest Asia, where the reported reason for migration amongst Indian doctors has moved from the pursuit of a better place to live to the pursuit of self-betterment. And that, of course, in itself is a direct function of the emerging nature of India's middle class. And so effectively now, the majority of doctors who come to work in the NHS come to learn and work within the NHS, so that their value on return is higher. And that is a paradigm shift. That's very different, actually, from other healthcare professionals. And the reason I bring that out, really, is because there are no two migration pipelines that are the same, in my opinion. And I think you can look at the push, which can be anything from very poor local conditions to a governmental push, the likes of which we see in Kerala and the Philippines for adult nurses, which is fundamentally about the economy of that particular state or nation. And if you look at other types of push, so Manipal University, for example, in Bengaluru, have a policy of developing partnerships to graduate nurses to move to other countries, because that attracts more nurses into nursing. Whereas obviously the situation is very difficult if you were looking at Zimbabwe, where fundamentally we have a critical mass of nursing, and removing one or two of them can make a whole local health economy collapse. So there isn't, there is a sliding scale here. And I think mutual benefits has to be individualized. And I think what we've wrongly done in this regard is we've allowed the free market to decide how these pathways should run. And believe me, it's very difficult to control that. But nevertheless, I think that there needs to be more public sector expertise in migration and the pragmatics of migration, so that we can look and identify mutual benefits in each of those migratory routes and in each of those individual professional groups. The corollary to that is that there are some fantastic examples of circular migration. And I think by and large, any migratory activity which is based on global learning, in other words, the improvement of an individual professional in terms of their scope of practice, I think is by and large a good thing. But there are obviously exceptions to that. And I think focusing on the educational professional development elements of migration actually moves it much closer to an ethical paradigm than workforce deficiency. From that, it's a personal opinion rather than the opinion of the government that I work for.
One thing you've not mentioned there, Jed, which you probably ought to, is the work that you guys have done in Uganda with your Earn, Learn, Return programs. Because at the end of the day, that's exactly what you're talking about, isn't it? It's creating a pathway that brings nurses in to assist with their training in the UK and then ensures they go back.
Yes, and we've got several partnerships like that. One in Thailand, one for Vincent of the Grenadines. We had a very, very big one in India with 8 states in India, which we've now handed over to our partner arm's length bodies. And then we've got a series of them in medicine as well. And they are very popular programs. They're very popular countries, but each one of them, though, Steve, has required a critical mass of mediation and mediatory skill, which makes sure that there's mutual benefit. And the problem is that you design these pathways and walk away from them, and you lose the regulation of those pathways, and all of a sudden they revert to a market. And I think that's when we get ourselves into problems as a Western economy, to be honest.
So the message really is that you can't leave migration unfettered to market forces. There has to be an element of regulation to ensure, which I guess is where the WHO recommendations are coming from, and where some of the ideas that you're talking about are coming from.
I think there has to be an element of public sector expertise as well, which I think is really important, and it's very often lacking. So that there has to be a lot of this is nuanced and informal. It doesn't have to be statute, but it's about relationship development. It's about ensuring you understand what both partner would want in this, and doing it within a government to government or peer to peer or institution to institution partnership envelope always helps.
Brilliant. I think I saw Alistair Curry's hand go up a minute ago, and then we've got Kit and Anthony who also want to come in. Alistair, did you want to make a point?
Thanks, Steve. It was just a really small point, actually, or almost a question. But the extent to which, in some sectors at least, we don't need migration anymore. We've talked about the digital acceleration, and clearly the mental health crisis, the fact that only 1% of global healthcare spend is on mental health, and we've only got 1% of global healthcare workers working in mental health, and yet COVID has created this huge boom in mental health issues and concerns. But mental health care specialism doesn't necessarily need physical contact in quite the same way or to quite the same degree as other healthcare offerings. So is there a greater opportunity, therefore, for more international collaboration with that digital acceleration, particularly in mental health? and what can we do to accelerate that, to increase secure data sharing across national boundaries. It seems to me a lot of things sort of knit together in that particular little area.
It is an interesting point around mental health, and something that I've been doing some work on with a couple of clients recently. There is an interesting point around the delivery of mental health across borders, in the respect that some mental health concerns are informed by local culture. So, for example, I was working with a company that wanted to provide remote mental health care services in the Middle East, where there's a lot more sensitivity around mental health care. There was one particular example of an organisation that was trying to provide counselling to insured patients in Dubai, and found that nobody turned up for the counselling sessions because the stigma around mental health was such that they didn't want to show their faces. So there is an element, I think, of cultural context in the delivery of mental health. Anyway, that's probably a debate for another day. We've got lots of hands up. So Kit, to you, and then to Anthony Hazar. Kit.
I wanted to just return to the original question and stick with the point on mutual benefits. So, the question is, are we at risk of worsening the inequality through migration to higher income countries? And of course, the obvious answer is yes, but we're here to look beyond the obvious, aren't we? And so it's yes, unless there is a real focus on delivering a true benefit back to the country that has delivered the healthcare worker to the high income country. And there are some paradoxes here, or conflicts, in terms of how the UK is focusing its efforts. So we follow the WHO Code on International Recruitment. We don't recruit from vulnerable countries without a partnership agreement. And so we are regulating migration into the UK in that sense. But at the same time, we're spending money through official development assistance on building up the healthcare workforce in that country, who are then potentially moving to the UK. So we wonder at THEP whether there are, and we know that the DHSC wonders about this as well, are there more creative ways and more sensible ways of using both recruitment and our official development assistance spending to strengthen healthcare systems in those countries that we're recruiting from, so that we do recruit from them, but there is genuine benefit back to those countries, either in terms of growing the workforce, or strengthening the training of the workforce, or supporting better distribution within country.
It's a really interesting one. And Alistair Russell, I'm going to come to you in a minute to ask you this question, because I think there is a really interesting point around the benefits to the NHS of migration, the number of the proportion of NHS workers that do come from overseas, and the overseas links that come from that. I'll let you think about that for a minute, Alistair, because Anthony's got his hand up and is struggling to find his mute button.
There we go. So it was really just sort of an idea that sprung to mind listening to what some of our other colleagues have been talking about. And I was just thinking, a lot of these exchange programs tend to focus on doctors, nurses, people who are licensed, and quite often to quite specialist facilities in the UK. And I wonder what the group who has sort of, I guess, more experience with exchange programs and facilitating these sorts of peer-to-peer learnings, what they thought about bringing in sort of primary healthcare people or allied health professionals on exchange programs to countries like the UK, Australia, US, to make those jobs more appealing in the low and middle countries, to keep and potentially increase the size of the workforce for those sorts of roles. It's not something we hear, or I hear much about, but it's just an idea based on what people were saying.
I suspect Jed might have some thoughts on that one. So before I go to Alistair, I'll let Jed answer that question.
Yeah, you're reading our minds, Anthony. We have just launched a paramedicine scheme, and a radiographer and learn and return program as well, where we've got doing 190 interviews for the paramedicine scheme in February, and we have had an awful lot of interest in radiography, and they are predicated on bringing radiographers into the country and moving them from a generalist radiographer into a specialist radiographer. biographer, which gives them an extra skill on the way through. Some of the allied health professions, of course, don't exist in other countries. We're having a nightmare with podiatry because we appear to be the only country who has a reasonable level of an independent professional podiatry group. But I think that is an opportunity for mutual benefits as well, because we can generate blended learning programs. Because a diabetic foot, of course, is a problem which is not only ubiquitous but growing in low, middle, and emerging economies. So there are some real opportunities as well for strengthening mutual beneficial partnerships in this with allied health professionals. So completely with you on that.
So to come back to the question that I posed to Alistair a moment ago, migration in the NHS. I mean, it's a really important thing for the NHS, isn't it? And it does actually allow NHS organisations to generate some really useful international relationships.
Absolutely, Steve. Yeah, it's vital, both for clinical delivery, but also, I suppose, the culture and the whole energy of the place. It brings so many benefits to it. And I'm just going to try and answer this question for you, a few key points. I think the first thing to say is that in Imperial, yes, we do international recruitment. We recruit from places like Canada, India, Australia, and the Philippines. We do follow, of course, the Department of Health Code of Practice with that. And but I suppose, it's to that point we discussed earlier around digital and the benefits it's bringing. And I'll link this back to the international. So it's where digital has really helped us is the ability for us to be able to package up the knowledge and expertise within the trust. And more importantly, share that and actually develop it with people internationally, because we certainly don't know all the answers. We've got challenges every day, and I think we're better off working together to try and fix things. And that's certainly to Jed's point around building up peer-to-peer relationships internationally, which, coming back to the point of immigration and having a workforce that are coming from all around the world and congregating here in Imperial, we benefit from. Because I suppose what we're really interested in is how can we now take that to the next level and start to formally form international partnerships, because for so many years they've been quite informal, based at kind of a clinician level. So at the Trust, for example, we've recently formed the affiliate network, and we're starting to, we've got one affiliate now, one hospital, and we're hoping to potentially go to the regions where we are recruiting and have affiliations with hospitals there and start to transfer, but also develop knowledge and expertise and innovations together. And of course, coming back to the thing, digital enables that to happen, because one of the biggest challenges we've got is capacity on both sides. And so we have to be really careful about how much do we draw upon the front line to support these things when they've already got a full-time job doing that. So digital, one, enables the transfer, but it also enables you to package things up and potentially reach a lot more people without drawing too much on the resource.
A really, really useful point, Alistair. Thanks very much for that. We're getting a little bit short of time. I always love a debate that feels like it could go on a hell of a lot longer than it does, because it means it's interesting. But I do want to ask that key question around universal health coverage, because I think it's a UN Sustainable Development Goal. It's something that we're aiming towards. Jim, to come to you on this question, how does the sort of decline, I guess, or the worsening of the crisis around workforce affect our delivery of WHO? When can we actually create true global health coverage?
So we're almost at the end of 2021. In 18 months' time, we're at the halfway point for the Agenda for Sustainable Development. 7.5 years into this 15-year process, and where we set the ambition for universal health coverage, just like we set the ambition 40 years ago for health for all. The predictions, Steve, are that with the financial downturn that we anticipate, that the World Bank and the IMF are predicting with our WHO colleagues, with the challenge there is many countries, there are 40 to 50 countries, are going to be really, really dependent on global solidarity to be able to make progress towards that ambition. And so I'm really encouraged to hear people like Jed and Alistair Charlotte, Kit, talk about these peer-to-peer relations, the international relationships, because we're going to have to look at that support and the use of digital. We're no longer in knowledge transfer uniquely, but the use of digital tools to engage, communicate, share information on what can work under what circumstances is going to be absolutely critical. It's not only and calling for greater solidarity around investments in education, health, social protection. We have a role as global citizens to be doing that. So that's the projections, is that we're not we don't want to just come straight to a simple language of being off track, but there's a fundamental and some moral considerations here about how do we get political ownership and investment in education, health, social protection.
Really useful, Jim. So we've got about 5 minutes left. So I want to just have a quick run around the panel just to get a final thought from each of you. What, for each of you, is the one crucial thing that we should be thinking about right now that can help us to mitigate this crisis over the next 10 to 20 years? And I'll go first, I think, to Charlotte, if I may.
That is an impossible question, Steve. I couldn't possibly give you one single answer. But one thing that I was thinking as we were sort of going through these questions is that something that hasn't come up is the role of patient empowerment and patients doing things for themselves. And I've heard some really, there's some amazing stories about digital therapeutics and the impact that can have on demand for care further in the system. So perfect.
Brilliant. There you go. You tell me it's an impossible question, then you answer it. This is why we love you. Alistair, you wanted to come in. Alistair,
I just wanted to come in after Charlotte, because what she said was absolutely spot on, really. And I think I just wanted to give you an example, really. So here at Imperial, we've developed the integrated family delivered care within our neonatal provision. So this is around where we teach the family how they can actually care for their newborn. So, for example, tube feeding, changing and monitoring. So it just starts to take off some of the pressure from the nursing team. Plus, obviously, they can then transfer that home when they go home. So I just wanted to give as a real life example, just to follow on from Charlotte's really good point.
So 2 votes for patient empowerment, which of course is the thing we haven't talked about. Alistair Curry, have you got a thought for us in terms of a thing that we should be concentrating on if we're going to try and mitigate this crisis?
Yeah, I think so far as the crisis is a global workforce, healthcare workforce crisis, I think for me, one of the things we've talked about a couple of times is the importance of supporting staff through change and not changing everything all at the same time. I think we've got to pace ourselves. So I think there's a risk in coming up with too many bright ideas about what needs to be changed and then driving those changes through. And we've already got a stressed, burnt out workforce, and it's about supporting them through that, through those big changes that are afoot in terms of collaboration and integration and all of the other changes that we've talked about.
Kit, what's your final thought?
So first, I add my vote to patient empowerment, but I'll say something else. I mean, I think the one thing I would say is build partnerships that are respectful and reciprocal, whether that's between healthcare workers and patients to empower them across borders, between peers or governments. But I feel that is the way forwards from which all of the other things we've spoken about can flow, and which is essential really for that to happen.
Anthony, what's the one thing that you think could have the biggest impact on this problem?
Tricky question. I mean, I think what everyone said has been important. For me, I think that's kind of the point, that we can't look at it in isolation. We need to take a holistic view and look at the whole health system, whether it's training, partnerships, patient-centered care, looking at the financing, migration, etc. It's all important and they all impact on each other. So I would say a holistic view on the health system to try and solve the problems.
Jess?
Well, my thunder's been stolen, particularly by Charlotte. I was going to say partnership, but here's one for you.
She does that.
I think we should be investing in levelling the playing field, and what I mean by that is that we should not allow local genius and potential for the future to transform local health economies to escape through the net, and that means the identification and mentorship of future healthcare leaders in rural communities and through partnerships, because they're the people ultimately that are going to make us more health secure and pandemic prepared in the future.
And Jim, a final word to you.
I think the biggest crisis we're going to see is one of equity, Steve. And shortage is relative everywhere. We've heard many of the UK examples nationally and in facilities. You know, the distribution of the workforce, the capacity of the health system in urban areas and rural areas and around high income, low income. We're going to see a regression worldwide in equity. And so we've got to use all of the solutions to try and address that universalism principle to at least try to ensure that no one is left behind.
And I think that's a really, really good point to end on. My reflection listening to this, I mean, what a brilliant panel, and so many different elements to this topic. You know, we've talked about efficiency, we've talked about volume, we've talked about the idea of getting healthcare professionals to operate to the top of their license. We've talked about remote consultation. We've talked about the ability to deliver education and training remotely. We've talked about the need for ethical practice in migration, and what Jed talked about the sort of public sector overview that needs to take place to ensure that we don't just revert to market forces. We've talked, albeit latterly, and it's a shame we hadn't had more time to talk about the idea of patient empowerment and people taking charge of their own care. The problem to me, it seems, is that this crisis, and I think Anthony summed it up in his final thought, it doesn't have a silver bullet, it doesn't have a single solution. What we have to do is find a way of working all of these things together in concert if we're going to solve that problem. And I think the issue with that is that, as we know, tackling something this big with this many moving parts in it is an incredibly difficult challenge, and something that I think we could talk about all day and all night. And ultimately, it comes down to what Jim said at the very end. It's about equity, it's about equality, and it's about somehow delivering healthcare for everybody on the planet. Big problem. We haven't got an answer. We haven't solved it. But at least we tried to have a really useful and really, really interesting debate. So thank you again to Jim Campbell, to Alistair Russell, to Alistair Curry, to Kit Chalmers, Anthony Hazar, Charlotte Refson, and Jed Byrne for being a really, really fabulous panel on a very, really big topic. And that's it from the Healthcare World Festival for November. We'll be at Arab Health at the end of January. We hope to see some of you there. And we will return with more sessions like this in the spring after Arab Health, so February onwards, and we look forward to seeing all of you again there. Please do get in touch, give us your feedback, give us your thoughts, read the magazine as it comes out. Thanks again to everybody, and we'll see you very soon. Thanks very much. Goodbye.